Okay. Hi, everyone. So I am going to be presenting a case that was seen on the general neurology service earlier this year. So this is a 71-year-old female. She presented with vision changes, generalized weakness, confusion, and some gait difficulties. She had been having generalized weakness and confusion for about the past year per her daughter. And the vision issues, she had a lot of difficulty describing, but when we really probed her a little bit more, she said she was having difficulty keeping her eyes open. And then her daughter said that she wasn't really moving her eyes. She was kind of turning her head in order to look different places. She also had several weeks of dysphagia and no recent weight loss or other complaints or health changes. So her initial exam, she was a little bit drowsy, but alerted to voice. Her pupils were 4 millimeters and unreactive. She had ptosis of the left eye and bilateral complete ophthalmoplegia. Her palate elevated asymmetrically. The left side rose higher than the right. And then her tongue had a slight right deviation with weak protrusion into her right cheek. She had no motor issues, full strength. And then at some point later in her admission, we noted that she had some facilitation of her reflexes, but they were 2+ and symmetric. And then she had some dysmetria on finger to nose and heel to shin testing. So our initial hypothesis, we were thinking with the ptosis described to us initially, potentially myasthenia gravis, like primarily ocular. And then Miller-Fisher variant was also in the differential Lambert-Eaton myasthenic syndrome with the facilitation of her reflexes and Bickerstaff brainstem encephalitis. She ended up getting an MRI that was unremarkable. She had an EMG nerve conduction study that didn't show any evidence of a neuropathy, though we weren't really able to test a weak muscle. She had a Mestinon trial that showed no improvement in her symptoms. She got 5 days of IVIG, no improvement while inpatient. And then we started her on prednisone and was discharged on a prolonged taper. But essentially at the time of discharge, her exam was unchanged. She still was unable to move her eyes. She still had the ptosis and the dysphagia. So she went to rehab and sometime after discharge, her GQ1B antibody did return positive. So her syndrome was consistent with a diagnosis of Fisher-Bickerstaff syndrome, which is a combination of elements from Miller-Fisher syndrome and Bickerstaff brainstem encephalitis, occasionally overlapping with GBS. The anti-GQ1B antibodies are present in both of these diagnoses. And just kind of outlining the features of both here in this graphic and how they overlap. But essentially you see ophthalmoparesis and ataxia in both. With Miller-Fisher syndrome, you typically have areflexia. And then with Bickerstaff, you sometimes can see hyperreflexia, though the reflexes aren't as helpful as they are with the absence in Miller-Fisher syndrome. So ultimately, she completed the IVIG, went to rehab, and followed up with Dr. Lee 2 months later and was doing a lot better. Her confusion was mostly resolved. Her eye movements had improved in the 3 weeks after discharge, and she was returning kind of back to baseline. And from what I could see in the literature, it seems that this is usually a one-time kind of hit. And once you're treated and resolve, usually you do pretty well. But yeah, that's all.
All right, thank you. This today? This one? This is my intro, though. It's not all about you, sir. Just teasing. All right. So Very happy to introduce today's grand round speakers, Sweta Sengupta and Jaskiran Vidwan, two of our wonderful headache clinicians and scholars. Sweta has been with us for a while. She's assistant professor and currently the director of the Headache Fellowship. She was a resident here at Duke and did her fellowship here. And we're so happy she decided to stay on. Jaskiran is an assistant professor of neurology. She is not the director of the Headache Fellowship program, but at some point in the future, that's a distinct possibility. She went to Michigan State, where I visited, and did her headache fellowship at the University of Michigan. And then after a winding road has found her way to Duke, and we're very happy for that. And today's lecture, which is a great one, they're going to talk about at the heart of the matter, migraine is a risk factor for vascular disease. So now it's yours. Yours is the bottom one. This one? It's the latest. There you go.
Okay, so one thing I wanted to point out was that Rich is wearing a UNC shirt. So.
$15.
So our topic is at the heart of the matter, migraine as a risk factor for vascular disease. And how we came up with this topic was based off of the fact that cardiac disease is one of the leading cause of death in the United States. And in neurology, we oftentimes talk about the overlap between or the risk of ischemic stroke in migraineurs, but we don't talk as much about the relationship between migraine and cardiac disease. In addition, patients who have migraine and cardiac disease can be a difficult patient population to treat. And so we wanted to kind of delve a little bit more into that. We report no disclosures. And our objectives are as follows. So we're going to first talk about what makes migraine a risk factor for stroke. Then we're going to talk about the relationship between migraine and cardiac disease, followed by clinical concerns in migraineurs with cardiac comorbidities, and then medical management of migraine in cardiac patients. So the link between migraine and cerebral and cardiovascular disease. So migraine and stroke. Migraine and stroke association has been known for some time. In 1975, the Collaborative Group for Study of Stroke in Young Women found that the relative risk of migraine with aura is doubled compared with migraine-free individuals. In addition, multiple prospective and population-based studies have validated this. And in a Dr. Etmanen 2005 study, they found that the pooled relative risk was 2.16 in migraine for ischemic stroke, and the pooled relative risk was 2.27 in migraine with aura for ischemic stroke. Other risk factors that increase association for ischemic stroke in migraineurs include being a woman, age less than 45, oral contraceptive use, and smoking. However, the risk of stroke in those with migraine without aura is uncertain. So this is a review of 5 meta-analyses that look into the association between migraine and stroke. And on the top, you can see the number of studies. And as you can see, patients with just all migraine and being a woman have an increased relative risk for ischemic stroke, as well as below the age of 45, OCP use, and smoking. But what to look at really is when you have migraine with aura across the board, there's a 2 times relative risk of ischemic stroke. And you can see that throughout all the studies. However, if you look all the way at the bottom, migraine without aura, oftentimes the increased risk for ischemic stroke is barely above baseline and oftentimes not clinically significant. In addition, there's a higher risk in those with higher frequency of attacks and actively having migraine. And below, this is a McClellan 2007 study, which is a case control study. And they looked at patients who had more than 12 attacks per year, and the odds ratio for ischemic stroke was 1.7. However, those who had less than 12 attacks per year, odds ratio was 0.9. In addition, they also looked at the bottom of those who had started to have migraines within a year, and there was an odds ratio of 8.3 for ischemic stroke. So as you can see, those with higher frequency of attack and active migraine have a higher risk. However, there's no conclusive evidence that severity of migraine attacks influence the risk of ischemic stroke. We also talk about how migraineurs may have a greater predisposition for white matter disease. And there are studies that say that there is no association, and other studies that mention that there is association. This 2004 article mentions that migraineurs are at 4-fold increased risk for white matter abnormalities. And this risk is even present in younger patients less than 55 who do not have comorbid cardiovascular disease risk. Some studies found no difference in the prevalence between migraine without aura and others, between migraine without aura and migraine with aura. But other studies found that there's a higher prevalence in migraine with aura. This Cruitt 2010 study found that the patient population that had migraine and subclinical infarctions, most of them actually had a predisposition to the posterior circulation. However, it's still unknown whether these brain lesions do have any negative long-term functional consequences. Some studies say that it does, other studies do not bode true. For instance, there's a prospective study of 12,500 patients followed for 21 years, and there was actually no association in this specific study between migraine and incident dementia. Now in older age, it's a little bit different. They found that the longer cumulative exposure to migraine with aura is not associated with increased stroke risk in later in life. And then this Monteith 2015 article where they studied patients who had an average age of 68 and they followed them over time. They actually found there was no association between migraine and risk of either stroke or combined cardiovascular events, unless you smoked. So smoking seems to increase this predisposition. In addition, migraines occurring later in life can be a risk factor for stroke. The study actually paid attention to whether their migraines started before the age of 50 versus after the age of 50. And the patients who had migraine onset after age 50 had a higher risk for ischemic stroke. So why is migraine with aura associated with increased stroke risk? There are some theories behind this. One is that we do know that migraineurs at baseline have an increased risk for cardiovascular disease risk factors. There's a study that showed that migraineurs, compared to those with no history of migraine, have a greater risk of developing hypertension. There's a study in middle-aged women where they found that migraine with aura correlated with greater carotid stiffness and plaque formation, while there was less association in those with migraine without aura. There's a small study that showed that obesity and being underweight had an association with stroke, and then also with migraine. And then we found that there was a study that showed that migraine with aura patients actually had higher triglyceride and lipid levels. Another thought is that we think that migraine with aura, or the aura aspect, is from something called cortical spreading depression, which is it's kind of like a charge that goes across the brain. And typically this is accompanied by oligemia or decreased blood flow. And then the migraine itself is from hyperemia and vasodilation. So one possibility is that in some patients, there is an inappropriate vasoconstriction, and that's what's putting them at risk for stroke. We also know that matrix metalloproteases are released in patients or higher in patients with migraine compared to without migraine. And matrix metalloproteases can impair the integrity of the blood-brain barrier, causing potentially local tissue damage. Patients with migraine are also on medicines that increase stroke risk in itself, like NSAIDs. There's also a concern that migraineurs have an increased risk for hypercoagulability. There's been studies where endothelin 1, which is a vasoconstrictor, is elevated in migraineurs. They have a higher chance of having activated and higher levels of von Willebrand factor than those who don't. Prothrombin factor 1.2 is a breakdown product of prothrombin. There's studies where migraine with aura have a higher prothrombin factor 1.2. There's also this genetic variant called MTHFR C677T, which is more common in migraineurs, that is linked to elevated homocysteine levels, which is a risk factor for stroke. And then there are some studies that show that they have a higher chance of having antiphospholipid antibodies. There's also increased prevalence of PFO in patients with migraine, and do they have some genetic factors that increase their stroke risk? And this is a chart or a flow chart that kind of goes through what we discussed of some theories in terms of why migraines may increase risk for stroke. So now we're going to switch gears and we're going to talk about migraine and cardiovascular risk. Multiple large studies show that migraine, particularly with aura, have consistently been associated with increased risk of cardiovascular disease, including cardiac mortality. However, what's interesting is active migraine without aura was not associated with increased risk of any cardiovascular disease. In this Kurth 2009 article, what they studied was the correlation between migraine frequency and development of cardiovascular disease. And what they found was those patients who had low migraine frequency, where they had less than monthly migraine, had actually a stronger and more significant association with major cardiovascular disease, as opposed to those who had more frequent migraine, including those who had more than monthly and more than and equal to weekly headaches, which is unexpected. So why does migraine increase cardiovascular risk? The association between migraine and cardiovascular disease remains unclear. Some of what we use to describe why migraineurs are at risk for stroke also holds true with cardiovascular disease. However, for instance, PFO does not explain cardiovascular events other than stroke. The theory about inappropriate vasoconstriction due to cortical spreading depression does not explain this. As mentioned earlier, we do know that migraine with aura, they have a higher association with elevated cholesterol, higher blood pressure, increased Framingham risk score for coronary artery disease, but they still have a risk, elevated risk, even controlling for these factors. And so we do know that they're potentially more hypercoagulable. And do migraineurs have maybe a genetically determined arteriopathy? And kind of mentioned earlier that there was that paper that looked at the frequency, that lower frequency had a higher correlation with risk of cardiovascular disease. If migraine itself increased risk of cardiovascular disease, wouldn't we expect that increased frequency would lead to further risk increase? So there's more to this that we just don't understand. So now we're going to talk about some clinical questions that we may encounter in migraineurs with cardiovascular disease. So one question that lots of people will get is, does high blood pressure cause headaches, or is it the other way around? Acute migraine is frequently blamed as a cause for elevated blood pressure during clinic visits or in the emergency department. So in a small study, which was a prospective study of blood pressure measurements in normotensive patients, they had them check their blood pressure early in a migraine attack at the peak pain, and then 1 hour after the migraine attack. And they actually found no consistent evidence of hypertension. And actually about 5% of these patients had diastolic hypotension recorded in relation to their migraine attack. And then in a Friedman 2014 study, they looked at they analyzed national probability samples of all US ED visits and compiled data from 3 ED-based migraine randomized control trials. And there was an association between head pain and elevated blood pressure on presentation, but there was no correlation between improvement of pain score and reduction in blood pressure in this specific study. So essentially, the relationship between blood pressure and headache is more nuanced, and it's not very straightforward. So the other clinical consideration that we're going to talk about, this was actually presented at the American Headache Society conference this year, and it was presented by Dr. Ailani. And I tried to see if they actually published a paper yet, and they haven't. So this is mainly based off of her slides and her talk. So it was labeled cardiovascular outcomes associated with oral triptans among migraine patients with a history of cardiovascular conditions. And so this was a longitudinal prospective study where they selected adults treated with acute migraine treatment, who were using either of these three prescription types: triptans, non-aspirin antisteroidal medications, opioids, or butalbital. And they had to have at least one cardiovascular condition. And they were gathered between January 1st, 2006 and December 31st, 2020 at Mass Gen in Brigham. And they had to use they couldn't use both triptans and non-aspirin NSAIDs at the same time. So what they really were trying to do is compare all three individually to each other. They had to have migraine, and they had to have, they could not have cluster headache as a diagnosis. And then they followed them for 60 days, looking at cardiac events that developed. The baseline characteristic of the incident medications are in the population that they studied are listed below. And so you can see that triptans, opioids, non-aspirin antisteroidal, and mainly opioids and butalbital were used in patients with one cardiac risk factor. The mean age was between 40s to 50s, mainly female predominant. And you can see at the bottom that the patients with opioids and butalbital and non-aspirin NSAID use had a higher baseline cardiovascular risk probability compared to those using triptans. In addition, they also had more aspirin use compared to triptans, which makes sense because typically in the clinical setting, you're going to pick non-triptans. Most people will pick non-triptans for patients with cardiac risks. And then they looked to see what kind of medicines were prescribed under each of the three categories. And it was mainly sumatriptan, butalbital, oxycodone, and ibuprofen. And then they looked at major adverse cardiac events, or MACE, over a 60-day period since the incident medicine was used. And this is the unadjusted results. But consistently, you could see that those who used triptans, whether it was major adverse cardiac events, non-fatal strokes, and non-fatal MIs, were actually less than opioids and butalbital and non-aspirin NSAID use. And when they adjusted for the fact that the opioid butalbital and the non-aspirin NSAID patients had a higher baseline risk for cardiac conditions, there was still a significantly less risk for major adverse cardiac events with triptans when they were compared. So ultimately, triptans were associated with markedly lower risk of major adverse cardiac events, non-fatal MI, and non-fatal stroke in migraine patients with a history of cardiovascular disease compared with opioids, butalbital, and non-aspirin NSAIDs. That's interesting. So now we're going to kind of shift gears and talk about how we treat this patient population. And we're going to discuss about these treatment modalities. So with opioids, much of what is written about opioids comes from this presidential advisory from the American Heart Association that was published last year. So opioids, we know, are associated with delayed gastric emptying, and patients who have chest pain and concern for MI, oftentimes they're treated with morphine and aspirin or Plavix on presentation. And one concern is that opioids affect the absorption of Plavix and aspirin. The clinical impact of morphine P2Y12 receptor antagonist drug interaction is currently remains unclear still. There is one study of patients with coronary artery disease awaiting bypass surgery that morphine actually caused a 13% reduction in coronary blood flow. And also in animal studies, morphine has been demonstrated to actually increase myocardial infarction size. In addition, opioids, even tramadol, is subject for abuse and dependence. And before 2014, tramadol was what we call a legend drug, where there was no control behind it. But then in 2014, it is a scheduled for controlled substance, which is the same schedule as like benzodiazepines. So opioids can also induce central sensitization and opioid-induced hyperalgesia. So we typically think opioids can help with pain, but there's a group of patients where opioids can actually cause the opposite effect, where it can exacerbate their pain over time. And many patients that they can become more refractory to other medications, including triptans. So there's a study of patients who are on opioids and they had less response to rizatriptan. So ultimately, opioids should only be considered when other options have been tried or deemed unsuitable and the potential for abuse has been addressed. Fioricet is one of the combination analgesics that contain butalbital, caffeine, and acetaminophen. There's also Fiorinol, which contains aspirin, and then there's versions that also contain codeine. They have not been actually studied in placebo-controlled trials among patients with migraine. It was actually studied in tension type headaches. Butalbital is a barbiturate that can produce intoxication, withdrawal symptoms. There are cases where people have to wean people off of Fioricet with phenobarb, tolerance and dependence. And also the fact that it has caffeine in it, you have to be careful with using this in patients with cardiac arrhythmias. Non-steroidal anti-inflammatory drugs. One of the original concerns for this group was in 2004 when this VIGOR trial brought up concern for the high risk of MI associated with rofecoxib, leading to its withdrawal from the market. And there's a thought that maybe the cardiovascular risk may actually vary, even among the non-selective anti-steroidal medications, with naproxen having the better safety profile. However, there's 2 non-inferior RCTs in arthritis patients that found no difference in cardiovascular risk when comparing individual COX-2 selective non-steroidal anti-inflammatory drugs with individual non-selective anti-inflammatory drugs. So it's still unclear. All right.
So to continue our discussion about the treatment of migraine in patients with cerebral and cardiovascular disease, I wanted to step back for a moment and talk about the underlying pathophysiology of migraine with aura. And Sweta already talked about this and touched on it. So with migraine with aura, the current widely accepted theory is that it is caused by cortical spreading depression. And this process is due to a wave of depolarization followed by hyperpolarization and inhibition, and leads to the development of migraine aura symptoms. The International Classification of Headache Disorders has defined migraine with aura. And it's important to point out that aura can present many different ways. You can have visual aura, sensory, speech, motor, brainstem aura, and retinal aura as well. And what's important to recognize is that the underlying pathophysiology of what causes visual aura is the same as what causes brainstem aura or motor aura. And yet our approach to treatment of these different migraine subtypes tends to be different, tends to vary. So brainstem aura was formerly called basilar migraine. And that was a term that was coined in the 1960s with the assumption that there was vasoconstriction of the basilar artery. But we know that that is less likely, so it's been revised as migraine with brainstem aura. So most of us, I presume in this room, would not hesitate to prescribe a triptan to a patient who presented with a typical migraine with visual aura. But what about a patient who has hemiplegic migraine or migraine with brainstem aura? The use of triptans in those conditions is highly debated, yet there are several clinicians who routinely use triptans for hemiplegic migraine and migraine with brainstem aura. And the reason is based on the clinical data that we have available and our understanding that the pathophysiology is the same as migraine with aura. Of course, the FDA does list contraindications to using triptans in those conditions. So I want to point out that because all of the triptan and DHE trials excluded patients who had hemiplegic migraine and basilar migraine, there are no randomized placebo-controlled trials looking at these patients. What we have to rely on is retrospective studies. And there are two retrospective studies that I want to point out. The first is one looking at 76 patients with hemiplegic migraine in Finland. And these patients were treated with triptan medication. None had any vascular events. One patient did develop hemiplegia, ataxia, and dizziness after being administered rizatriptan 10 milligrams. It's unclear if that was her normal aura symptoms or if that was attributed to the rizatriptan. And then the second retrospective study that is worth mentioning looked at 67 patients who had brainstem aura and 13 patients with hemiplegic migraine, and there was no reported vascular events. Still, because there is that group of patients, those with cardiovascular and cerebral vascular disease, that we tend to avoid triptans and DHE, lasmiditan was developed. It is different than triptans because this one selectively targets serotonin 1F. It is an agonist, and it works very similarly to triptans in that it inhibits the release of CGRP. It has been shown to be as effective as triptan medications when looking at two studies, the Samurai and the Spartan. The Samurai study included patients with at least one cardiovascular risk factor, but they explicitly excluded patients who had known coronary artery disease. The Spartan study, on the other hand, did include patients who had known coronary artery disease, clinically relevant arrhythmia, and uncontrolled hypertension, and they did not identify any contraindication or adverse side effects in use in those patients. So I want to step back and talk about the association of microemboli, migraine, and stroke. So in this study, microemboli was injected in the carotid artery of mice. And we saw that one of three scenarios occurred. The mouse was asymptomatic, cortical spreading depression occurred without ischemia, and in third of the mice, cortical spreading depression occurred with ischemia. So we know that there is this link between migraine and stroke, as Sweta has already highlighted. So like stroke, PFO has been associated with migraine, and we see PFO present in about 20 to 30% of the general population. Migraine with aura occurs in about 5% of the general population. And what's interesting is that we see PFO present in 50% of patients with migraine with aura. And so the question is why? Why do we see a twofold increase in patients with migraine with aura? One thought is that perhaps there's a genetic influence that leads to patients developing atrial septal defect and migraine. And then the other thought is it could be due to exposure of vasoactive substances, such as serotonin. So serotonin is somewhat metabolized when it passes through the lungs. If there's a right to left shift, what we see is that those serotonin levels and other vasoactive substances increase. And as a result of that increase, that higher concentration, when it reaches the cerebral circulation, it can stimulate receptors and trigger migraines in individuals who are prone to migraines. There have been 3 large randomized trials looking at closure of PFO in migraine patients, and all have been negative. I do want to talk about the premium trial and the PRIMA trial, because they did use the same occluder in treating migraine patients with PFO. So in the PRIMA trial, patients who had migraine with aura were randomized to either PFO closure, followed by medication management with aspirin and Plavix, and then for 3 months, followed by aspirin only for 6 months, or just medication management. And the primary endpoint was reduction in headache days. In the premium study, patients who had both migraine and migraine with aura were randomized to either PFO closure with medication followed by medication therapy, or sham PFO closure followed by medication therapy. And the primary endpoint of that study was the responder rate, defined as more than 50% reduction in migraine attacks. Sure.
Sorry, it should be showing that. Yeah, there it is. Thank you.
Oh, gotcha. My slides aren't okay. When we look at the results of the 2 studies, we do see that they're quite similar, but so we see that the results are similar, which suggests that PFO closure produces a consistent response in patients who have migraine. Unfortunately, neither study reached their primary endpoint, but what's interesting to note is that the primary endpoint in the PRIMA study was a secondary endpoint in the premium study, and vice versa. So if they had reversed their endpoints, these trials would have been successful. We are able to gain further information looking at subset analysis. So in patients who underwent the premium study, which is individuals who had migraine with aura and without, if we looked at those who had migraine with aura, with attacks occurring more than 50% of the time, the responder rate endpoint is actually met. We see 49% of patients respond versus 23% in the placebo group. And then also in patients who have frequent migraine with aura, we do see complete cessation of migraine attacks in 15.4% of those individuals. Likewise, in the PRIMA study, when they separated migraine aura days from all migraine days, they did see that there was a reduction in migraine with aura and a reduction in migraine with aura attacks. Further, 40% of patients who underwent PFO closure had were completely pain-free of migraine attacks with aura. So certainly this begs the question, how do we better select patients to undergo PFO closure? In stroke, there is an index known as the ROPE score, and that is calculated using stroke risk factors or cardiovascular risk factors, age, and brain imaging findings. The ROPE score, it tells the probability of finding a PFO in a patient with a cryptogenic stroke. So higher the ROPE score, there's a higher probability that that PFO could have caused the stroke. A ROPE score certainly does not mean that the PFO should be closed. There's a lot of other factors that go into play. I do want to point out that higher ROPE scores occur in younger people who have less cardiovascular risk factors, so their 2 years risk of stroke or TIA recurrence is lower. In migraine, we don't have any such index to determine if someone has a PFO, is it the cause of their migraine or is it an incidental finding? And so one thought is looking at individuals who respond to P2Y12 inhibition. This is a retrospective review of patients who were treated with clopidogrel at Columbia University. And if they responded to clopidogrel, they were offered PFO closure surgery. If they didn't respond to clopidogrel, they underwent testing to see if they were adequately, if they had adequate platelet inhibition. If they didn't, they were switched to prasugrel. And then if they had 50% headache improvement, they were offered PFO closure surgery. And what we saw is that out of 136 patients, 90 patients responded to antiplatelet therapy. 56 went on to have PFO closure surgery. And of those, 52 had headache improvement even after stopping the antiplatelet therapy. And this is with a 6-year follow-up information. 26 patients did not undergo surgery because their insurance did not approve it. And what we saw is that those patients still had headache benefit, some as long as 4 years. So the RELIEF trial is a future randomized clinical trial that will be looking at PFO and migraine again, and it hopes to address patient selection and determine which patients may better respond to PFO closure. So PFO closure can help migraines, but the reverse can be true too for some patients. There are case reports that atrial septal defect repair can cause new onset migraine, even in some patients who've never had migraine before. And the incidence of that is thought to be somewhere between 8 and 23% in the literature. So why is that? The short answer is we have no idea. But we do know that calcitonin gene-related peptide does play a path or plays a role in migraine pathophysiology. CGRP is actually also released in cardiac tissue. It's released in the right atrium, the SA node, the AV node. And so this study was a prospective study that looked at, does CGRP predict who may go on to develop headache, new onset migraine after ASD repair? And they measured CGRP levels before and after closure. And what they saw was that patients you can see in the black bar, who went on to develop headaches, they had lower CGRP levels before the procedure and then a surge in CGRP level after. And so perhaps CGRP levels can determine who may go on and develop headache after ASD closure. And they also found that people who went on and developed new onset migraine tended to have larger atrial septal defects. And the thought was that maybe the atrial septal repair, the deformity, the stretching of the atrial septum caused the surge of CGRP. And so taking that into account with low CGRP levels pre-procedure and large atrial septal defects, that may help to predict who will go on and develop new onset migraine. So let's talk about CGRP for a moment. So CGRP, major peptide that is known to generate the trigeminal vascular system and cause migraine. It's released both centrally and peripherally by trigeminal nerve endings. And it acts on three important areas, right? We know that CGRP acts on receptors on the blood vessels. So it can help with vasodilation in the meningeal arteries. It also acts on glial cells. So it can cause neural inflammation, a cascade of mediators that go on to cause migraine. But it also acts on the trigeminal nerve. So there's receptors so that it can continue to exaggerate the pain response. Patients with migraine have higher levels of CGRP. We know that. So it makes sense that blocking CGRP can help treat migraine. And this illustration demonstrates that the CGRP antibodies tend to act more peripherally. And in the CGRP antagonists, the small molecule, we believe they could have central acting properties. So to date, there are 7 CGRP antagonists. Rimegepant and ubrogepant are approved for acute therapy. Arenumab, fremanezumab, galcanezumab, and eptinezumab are all monoclonal antibodies for migraine prevention. And then there are 2 gepants. Rimegepant is also used for migraine prevention, and atogepant is the newest migraine preventative. So how safe are these treatments? We know that CGRP is a potent vasodilator. It's 10 times more potent than prostaglandin, 10 to 100 times more potent than substance P or acetylcholine. And we know from studies looking at ischemia that it helps with reperfusion injury. So if we block CGRP, what is the impact that it's causing the patient? So there are 2 case studies that I found in literature that I wanted to mention. Arenumab caused myocardial infarction in a 57-year-old woman on month 5 of treatment. And there's another case report that arenumab caused a thalamic infarct and posterior cerebral artery occlusion in a patient after a single dose of arenumab. So the cause and effect still have to be determined, but these cases do demonstrate the safety concerns with the newer treatments. So from a physiologic standpoint, we know that CGRP has protective benefits. In hypertension, it doesn't help to maintain normal physiologic blood pressure, but it does respond to pathologic increases in blood pressure. In heart failure, it helps improve contractility. It acts in a protective manner. And in ischemia, it prevents against reperfusion injury and also mediates preconditioning. So like CGRP has been targeted in migraine, blocking CGRP, there is a thought that CGRP analogs could help with cardiac disease. And in mice models, they saw that daily injection of CGRP analogs actually decreased blood pressure, decreased cardiac fibrosis, reversed cardiac hypertrophy. So there may be a therapeutic role there in the future for cardiac disease. This is a a study that looked at cerebral ischemia in mice. CGRP was administered in mice, and then they underwent occlusion of the middle cerebral artery. And what we saw was that there was a higher volume of cortical infarct. There was an increase in neural deficits. And this was believed to be due to a dysfunction in collateral blood flow in mice. So certainly this raises a concern that if you are going to use a CGRP antagonist in a patient with heart disease or in someone who has a heart attack or a stroke, will they be able to compensate and dilate the necessary blood vessels? And the Arenumab treadmill study does seem to alleviate some of those concerns. This was a randomized controlled study looking at the administration of placebo and Arenumab in 89 patients with heart disease, stroke. These are patients who had undergone cardiac bypass surgery. And they saw that Arenumab was non-inferior to placebo in terms of total exercise time. They saw no difference in ST segment depression or the time of onset to developing angina. So this study was reassuring that could use it in patients with cardiovascular risk factors. So to date, there have been several clinical trials looking at the safety of the monoclonal antibodies. And we also have post-marketing data, real life evidence. None of the studies have shown increased cardiovascular risks for patients who are on these treatments. What's interesting is when these medications first came out, the European Headache Federation, they actually, based on expert opinion, recommended against using these in patients with heart disease and stroke. They've since reversed their position, or I should say updated their position. Now they suggest that it's probably safe to use, but still on a case-by-case basis and with caution. So let's talk about the post-marketing data briefly with Arenumab. There were 61 cases of hypertension reported in patients who took Arenumab over a 2-year period, and hypertension was new onset in 31% of those cases. And of those, 46% of cases presented hypertension within the first week of taking it. So we do need to keep in mind this is a very small number of individuals. And when we look at the clinical trials, there was no indication of hypertension in the clinical trials. When we look at preclinical data, we see that when an Arenumab was administered at supratherapeutic doses, there was no change in coronary artery tone. And even in monkeys, in studies looking at monkeys, when Arenumab was administered 150 times the 140 milligram dose we use, there was no increase in diastolic, systolic, or mean arterial pressure. So I want to leave you with this pilot study. So certainly with all these concerns that we have about using CGRP, we do need more studies to know whether long-term inhibition is safe. And this study measured CGRP at baseline, at 1 month, and at the 6-month mark. And they saw that CGRP levels actually increased. It was a non-significant increase, but that suggests that there's probably upregulation over time caused by this prolonged CGRP blockade. And this might explain why there is a favorable safety profile. CGRP antagonists do not knock out CGRP. They reduce the signaling of the CGRP pathway. So it's a reduction, not a complete amelioration. So in conclusion, migraine does increase the risk of cardiovascular events. Triptans may be a safer option than opiates and NSAIDs. PFA closure, we do need more studies before we can recommend it, but it could be a promising option for patients who have refractory migraine and migraine with aura. And to date, the anti-CGRP therapy do appear to be safe and effective in patients with cerebral and cardiovascular disease. Right.
Some questions from the chat. Go right ahead.
So to me, the white matter change for migraine doesn't look like anything. Pathologic correlation, and I wrote that patient aren't necessarily going to stop falling over and something happens. You might figure out what is that? Do we know what that represents?
So Joel's asked, what are the white matter changes seen in the brains of people with migraine?
Yeah, I mean, they just say that it's kind of what we see with other
Sveta?
White matter. So in the description of the white matter spots, they describe it the same as white matter changes in patients with white matter changes from cardiovascular risk. So they don't really make I have to look into it actually more if there is a specific risk pathology wise between the two. But from what I was reading, I didn't look into it in too much detail, but they just described it in the same way, but there probably could be, I just don't know.
We don't know.
Yeah. But that's, it's true that the migraine spots tend to be smaller. They're more in the deep white matter or periventricular, so they do look different.
So I have a question. So migraine is associated with obesity. How come we didn't hear about any of that? I mean, which is also associated with cardiovascular disease. So how does that all fit together?
There is association with obesity that migraines can become more chronic in patients who have obesity. So it's a risk factor for chronification.
So they call in the statisticians. So Marvin asked a question that Tim sort of answered, which is, how do you do sham catheter, PFO closure? I mean, is that really, blinded, or what do they do?
Yeah, and I actually don't know the process of how they do sham, but I would assume that they are going in through the same way, but not actually doing a PFO closure. I don't know the ethics behind it, but I'm sure that it's been approved and used. I don't know what Tim's answer was, but.
It's very shambolic. So Tim said they did one study where they kind of put a catheter in a groin, but didn't go particularly far with it. I guess you could just anesthetize somebody, and what would they know? But anyway, I read one study once where they did a PFO closure and people's homocysteine levels dropped in half. And, so it's complicated what happens when they do that kind, who knows? Anyway, I think that's the end of the questions, and I want to thank both our Grand Rounds presenters today for doing just a fantastic job. So big round of applause, virtual applause. Thanks everyone out there, and be safe. All right, great job.
Miss Sarah.